This is On Shifting Ground. I'm Ray Suarez. When bacteria, viruses, fungi, and parasites change over time and no longer respond to medicines, it makes infections harder to treat. This increases the risk of disease spread, severe illness, and death, also known as antimicrobial resistance, or AMR. And AMR leads to deaths, morbidity, high treatment costs, hospital stays, losses in animal productivity, and economic and livelihood losses. It was responsible for approximately 5 million deaths in 2019 alone. One of the upsides and downsides of a long career in the news business is that you've seen certain stories live through life cycles, recede and then come roaring back again. This story remains as serious as it ever was. The phenomenon says more about human beings than it does about the stories. Exhibit A, growing antibiotic resistance. It's a real problem, especially as some serious illnesses over time don't really respond to the drugs that once worked perfectly well in tamping them down. They were cheap, they were effective, but now they don't work as well, and you may have to alter a well-known drug and begin the cat and mouse game again with a pathogen, or come up with something totally new, and that can be expensive. And the something new may have more side effects or be understood from the beginning to be more toxic. And here we are again. Jennifer Cohn joins us now. She's a clinical associate professor of infectious diseases and a scholar at the Center for Global Health at the University of Pennsylvania School of Medicine. She's part of the Global Antibiotic Research and Development Partnership. Dr. Cohn, welcome to On Shifting Ground.
Thank you so much for having me.
Well, one of the images that will stick with me from years of reporting on the border is walking across the U.S. border into Mexico and finding a long line of pharmacies waiting for the pedestrian right over the frontier. And you walk into those places, and without a prescription, you can buy powerful antibiotics, common antibiotics that you need a prescription for in the United States. And that sticks with me in part because I know that one of the culprits here is overuse. How are antibiotics being used in a way that constitutes overuse?
So sometimes we see antibiotics basically being available over the counter without a doctor or clinician's recommendations, and that can really lead to overuse, especially when the syndrome shouldn't necessarily be treated with an antibiotic, such as if it's a common cold or other viral syndrome that doesn't actually get treated by antibiotics. But we also know even with appropriate, perfect use, these bacteria are going to evolve. These bacteria are going to outsmart our antibiotics, and therefore, even if we fix all the inappropriate use, which would definitely help slow down resistance, we're still going to need new therapeutics, and we still need to make sure that antibiotic development pipeline is robust and that the innovations that come out of that pipeline are accessible to the patients who desperately need them.
I think you made an important point when you said that these tiny critters are going to evolve anyway. But we shouldn't be pushing down the accelerator. We ought to get more years of use out of our painstakingly arrived at long research drugs before we have to start arming up with something else. What are some of the common practices that Americans who have taken antibiotics from time to time might be familiar with that's pushing down the accelerator, making these difficult arrived at drugs faster life cycle drugs that we have to abandon sooner?
100% agree. We need to take that foot off the accelerator. And some of the ways that we as Americans can do this is by making sure we are consulting our doctors, making sure that we're describing our symptoms appropriately, and then also making sure we are not necessarily squirreling away an antibiotic in the back of the medicine cabinet that maybe we have from an old infection and then using it at a later time. We want to make sure that we're saving those antibiotics for when we actually have a bacterial infection. Now, the other thing that I would say is that clinicians like me actually need better evidence on how to use antibiotics appropriately. It's bizarre to understand, but a lot of times antibiotics are approved without necessarily the data and without necessarily the evidence in the exact infection or resistance pattern in which they're meant to be used. And so what we need to do is at the same time as making sure that we can accelerate the approval of these antibiotics through robust clinical trials, we also at the same time need to make sure that we are running additional studies in the target resistance patterns to make sure that clinicians like me can choose the antibiotics appropriately and have the evidence that I need and that other doctors need for appropriate use. And that's what organizations like GARDP are trying to do.
So you don't want to use a cannon to swat a fly. Are there subtleties in the level of response where you might not need the biggest weapon in the drawer to help somebody get through their illness?
Absolutely. And I think this is another way that we can take our foot off the accelerator. So one of the things that physicians and others depend on are good diagnostics. In the outpatient clinic, we might need point-of-care diagnostics that are cheap and easy to use, similar even to things like pregnancy tests. You can drop a sample on and you see a line for 1 line for negative, 2 lines for positive, and you can say, okay, this patient likely has this infection or this syndrome. We have rapid tests for some illnesses like strep throat, but not for everything. So where we have these tests, we need to use them better, and where we can develop additional tests to help guide clinicians and patients down the route of you need an antibiotic versus you need other therapy. We need those tests to be developed. And I would say the same thing goes for the hospitals. In the hospital system, we may have a much larger range of tests, especially in high-income countries. But there still are tests that are waiting in the pipeline and about to be released that we can really help determine and accelerate the appropriate treatment to patients by using these new tests.
One of the responses that I've heard a lot, just being alive and in the world, is when someone's not feeling well, another person will say, well, hey, go get an antibiotic. Should we be thinking about allowing our own natural response to infections to knock it down in 3 days instead of taking an antibiotic and knocking it down in 1, which brings closer the day when that antibiotic won't be as useful?
I think this is a really important point. So I would say 2 things. There's very interesting research that shows that for some infections, and I'm not only talking about viral infections, which would never be treated by an antibacterial antibiotic, but also even certain bacterial infections, if they're not serious, if you are not immunosuppressed, sometimes those infections can ride out their course and you can overcome them. And sometimes a tincture of time is worth it. Now, the other thing is there are a number of bacterial infections where we have good data that actually taking an antibiotic helps and reduces sick days, reduces other morbidity, or reduces the chance that the infection could actually spread and lead to something much more serious like sepsis or other bad complications. Now, the other good news I have here is that a large number, an increasing number of studies are showing that shorter is better. We actually used to think you might need 1 or 2 weeks of antibiotics for a given infection. And what we're realizing is in almost every case when you trial a shorter course of antibiotics versus that standard longer course, the shorter course is just as effective. And the good news is that will expose the patient to less pressure for their bacteria to become resistant. It is less of a burden for patients because who wants to be taking antibiotics for 2 weeks? And it's also less financial burden for the health system. So I think there's a lot of good news on the horizon here.
Once I had it explained to me that if you don't take your full course of antibiotics, the only bacteria that are left alive after you take half your course are the toughest, smartest, most adaptable ones. And what you're doing is helping them respond to being hit with these therapies. Is that no longer the way people are thinking about these things?
I think the way we have to think about these things is that for the target bacteria that's actually causing the infection, we want to give as short a course as possible. And that short course should be evidence-based. Now, we have on the horizon, but it's not yet ready for prime time yet, some suggestion that potentially for, again, a limited number of infections, you could even say take 2-3 days. And then if you feel better, don't take that 4th day. But that's still kind of in development. But what I would say is for the target bacteria, the shorter, the better. And we want to make sure that we have evidence that short course actually works for the bacteria that's causing the infection. Now, the issue is for all the other millions and millions and millions of bacteria that are in and on your body, they are also getting bathed in this antibiotic. And the amount of antibiotic that they're getting bathed in varies a lot from anatomic site to anatomic site. And it in some cases, it might be enough to kill those antibiotics. In some cases, the antibiotic level is just enough to induce pressure on the population of bacteria. So actually, it makes the resistant bacteria kind of survive, take over that population, replace it, and thrive. And thus, you might actually end up being colonized with a more resistant bacteria in the end. The shorter the course of antibiotics you take, the less chance that you're actually going to develop a resistant bacteria, so long as there is evidence that short course antibiotic will actually result in a cure for the target bacteria that's causing the infection.
We shouldn't be frivolous about the use of these medicines, I guess, is part of the bottom line here. They're not just killing the thing that's making you sick, right? I mean, there's other things going on in your body once you've put an antibiotic in your mouth.
That's exactly right. And all medications come with side effects. Some are greater and some are lesser. We only want to take a medicine if it's really indicated, and we work with our clinician to make sure we understand why it's being prescribed and what the indication is for. So we want to, again, limit the number of infections to make sure we're only taking an antibiotic for an infection where the antibiotic is indicated. And then we want to make sure we're taking it for as short a course as possible. And those are some great ways to take the foot off that accelerator of resistance as you described it.
Are there well-known, popular, widely used antibiotics that we've just had to take offline because they don't really work that well anymore?
Well, I'd say that for certain infections, that is the case. So, for instance, a common infection like syphilis in many countries is now resistant to an antibiotic. It used to be sensitive to azithromycin. Now, the good news is azithromycin is still active against many, many things. But what I would say is that especially for infections in the hospital setting, those are getting more and more resistant. And we're seeing this trend accelerate at a really alarming rate. Now, as you mentioned at the start of this conversation, this has been a problem that's been going on a long time. And in fact, it's a problem because control of infections and the ability to treat infections kind of underlies all of modern medicine. Everything from cancer care to safe surgery to safer childbirth. All of these things at some point will likely need an antibiotic over the population who needs cancer care or surgery or other interventions. But in some ways, because this is everybody's problem, it's become no one's problem. It's kind of the tragedy of the commons. So what we're seeing, unfortunately, is people know that this is an accelerating problem. And this is an accelerating problem, particularly in low and middle income countries. But at the exact same time as we're seeing this kind of coming catastrophe for modern medicine, we've, over the last decade, seen many pharmaceutical companies actually withdraw from antibiotic development. So rather than an accelerating, more robust and large pipeline of new antibiotics to help us make sure we have all the tools in the toolkit, we're seeing, unfortunately, that pipeline dry up.
Are there antibiotics that are becoming less effective, in part because the way human beings travel and interact with each other? There used to be parts of the world that were relatively discreet, and if an infectious disease was being passed around, it would stay in that community or that region. Similarly, if a medicine was being used, the attributes of its use might remain isolated in one place. I wonder if part of the challenge is, and part of the acceleration that we're seeing in the undermining the use of antibiotics, is that people from everywhere go everywhere, cough on each other, breathe on each other, and things that might have worked a little while ago might not as reliably any longer.
I certainly think we do live in a globalized world where people do and can travel, and that brings a huge number of benefits. But as we saw in the recent COVID-19 pandemic, things can also travel very quickly. Pathogens do not know national borders, and that is just a fact. And so in some ways, this also means that we are all going to succeed together in the fight against AMR, or we're all going to fail together.
One thing we saw in the struggle with COVID-19 was that a lot of countries wouldn't get a great grade in plays well with others. There was a lot of almost medicine nationalism that arose around understanding where COVID was from, how to fight it, who to take advice from, what national profiles of infection and comorbidities were. It was a little disturbing to see one kind of messaging coming out of, for instance, the World Health Organization, and then another kind of response coming out of national secretariats of health and medicine and treatment and so on.
Absolutely. And what I would say here is that I guess there's two things. One is that we don't have as what I would say as strong guidelines as we need, either at regional or kind of international level, on how to appropriately treat bacterial diseases, especially these resistant pathogens. And here is, again, where we need better evidence to inform guidelines for clinicians to use, and not just evidence to get a drug over the regulatory hurdle, but evidence that clinicians can actually use. And again, I think this is where product development and access partnerships like GARDP can actually help develop the evidence that populations need that goes beyond maybe what evidence is needed just to get a drug registered. And the second thing I would say is that antibiotics are plagued by very problematic supply chains and manufacturing. There's a lot of manufacturing bottlenecks, and in fact, very common antibiotics like penicillin or amoxicillin have recently undergone severe global shortages, and these are recurrent because only a few manufacturing sites make the ingredients necessary for these antibiotics. Now, I think there's a lot of interest in kind of what's called distributed manufacture, meaning more manufacturing sites around the world, because we saw in COVID what some of those very kind of narrow supply chains and a breakage in one supply chain due to what you are calling supply or medication nationalism can wreak havoc around the world. And so for antibiotics, this could be a real boon because even in times of complete calm without a global pandemic going on, we even then see shortages of antibiotics. So we certainly need to address those bottlenecks in manufacturing.
But do we also have to deal with the competing impulses of profit, of intellectual property protection versus the more idealistic notions of protection, of tamping down epidemics, of caring for the world's ill? Sometimes they work in perfect synchrony, and that's great, but sometimes they bump up against each other in ways that certainly during the COVID pandemic were not among our finest hours.
Indeed. And I honestly think that actually antibiotic development and manufacture is kind of this long-term example of where things are not going right. The current system is not actually supporting the innovation we need, nor the access we need. And so in some ways, we need a new system for antibiotic development, one that doesn't completely depend on the profit motive, and one that results in innovations that can be affordable and accessible to the people who need the most, which are mostly in low and middle income countries. And so again, I think this gets back in a way to saying we're all going to succeed together or we're all going to fail together. Everyone in the US, in India, in South Africa, we all need new antibiotics to treat some of these resistant infections. But in some ways, the fact that large pharmaceutical companies have exited, it means we need new players like nonprofit drug development entities to actually say, this is my public health mission, and I am going to put funding towards the research, working with partners in the settings where there is high resistance to actually bring forward the innovations and the evidence needed, and then making sure that they're priced at a price that's actually affordable both in high-income and low- and middle-income countries. Any new administration has a really important opportunity to say we are going to be the administration that stops this, decade of failure of poor drug development for antibiotics, of weak infrastructure to get the antibiotics to the patients that need them, and to make sure that we're thinking about how can we actually work globally to make sure that antibiotics are available and affordable, including for Americans. Because one thing we've seen actually with some new antibiotics that are for resistant infections, they launch in the US first, but the US actually doesn't have as many people who actually need that antibiotic as there might be in South Asia. So what if we worked to launch the product at an access-enabling price in both the US, but also in South Asia? Thus, there would be more actual demand for the product, and maybe the antibiotic company that started making the product would actually survive. Unlike what's happened time and time again is when they just launch in the market of the US, which is actually a relatively small market, they go under, and then the antibiotic is withdrawn from the market. We can't have that failure again. And I think the incoming administration really has an opportunity to turn that ship around.
Jennifer Cohn is part of the Global Antibiotic Research and Development Partnership, GARDP. Thanks for joining us, Dr. Cohn. Great conversation.
Thank you so much. This was really fascinating.
You've been listening to On Shifting Ground, produced in partnership with KQED, with funding from listeners like you. Today's episode was mixed and mastered by Matteo Schimpf. KQED's Jim Bennett is our technical supervisor. Jared Spord is our executive producer. Philip Yun is co-CEO of Commonwealth Club World Affairs. Our music is from Blue Dot Sessions. I'm Ray Suarez. Thanks for listening.